Welcome everybody. It's my pleasure to introduce our case today. It's really one of the few cases around the world. Our patient today is a ischemic heart disease patient that is 12 years old. This boy presented to us just a few weeks ago with acute chest pain with dynamic ECG changes. By revising the history and by revising his clinical data, we found that he's the fourth offspring of a family of 5 brothers that had one of his sisters is having familial dyslipidemia. By workup for this boy, we found that he's also having familial dyslipidemia with an LDL more than 400. After reviewing his data, his ECG showed with the chest pain and ST depression and AVR elevation, ST depression all over the ECG and AVR elevation. So already the patient already put on anti-dyslipidemic agents with dual high intensity statin and plus ezetimibe, and we added PCSK9, and we subjected the patient to Holter monitoring who confirmed ST depression related to his symptoms, and the patient starts to deteriorate and having syncope with the attacks of chest pain. So we proceeded to multi-slice CT who confirmed a left main disease. So we subjected the patient to the coronary angiography who confirmed the presence of a critical left main disease. And after reviewing the literature about how to treat such a lesion in this extremely abnormal and rare presentation for this age group, the data were conflicting with few cases that are presented all over the world. So a few data about bi-arterial grafting to LAD and circumflex OM and stenting of the left main. So our decision today is to go for a stenting of the left main, and this is a procedure for today. We are welcome you all, and we will go to step-by-step approach of this data. Sure, the intervention will be IVUS guided to optimize everything. We don't have data about left main in this age group, about the optimal size, the optimal diameter, and where we stop. So we choose to, I think it is mandatory to have IVUS guided procedure. We hope that everything will be okay. We'll enjoy to join us in this case. We hope that everything will be okay. Thank you and welcome.
All medication adjusted according to the body weight. Patient body weight is 25 kilogram. Aspirin is given in a dose 5 milligram per kg per day. Clopidogrel is given in a dose of 1 milligram per kg per day. Rosuvastatin is given in a dose of 10 milligram per day. Other medications, beta blocker in a dose 2 milligram per kg per day.
Hello again. We will start the case. I want to introduce the team. Our team today is Professor Magid Ramsis, head of the cardiology department at National Heart Institute, and I am Bassem Zarif from National Heart Institute, and Dr. Ali Jalal is assisting us, Professor Ghada Qazamel, and Professor Randa Zainuddin from the head of the department of the anesthesia. Dua for the head nurse, and Khalid, the technician who is responsible for the operating the cath lab. We are starting just introducing a femoral sheath of 6 French, and we start opacification of the lima. Have some for documentation, and we are starting just to engage the left main with GL 3.5. We had data from the previous angiography that the left main is angulated and having a critical disease with damping of pressure once cannulating the left main. So we'll start. We're taking the first picture, and we'll show it to you and come back to you again. I told you before that once engaging the left main, the pressures come down. So we start from the flying position just in the cuspogram, leaving the guiding catheter is trying to just wire the LAD and circumflex to have two wires. And this is the job that Professor Magid is trying to do it right now. In the cuspogram, once we have the two wires on the LAD and circumflex, we'll try to bleed dilate the left main just to have a seat for the guide to start a comfortable procedure, because most of the procedure while the guiding on the aorta is not having enough support to continue the procedure. That pressure getting just to engage the abnormally originating left main. So we tried after shaping of the GL 3.5 to have adaptation to the curve and the small aorta in this young boy. So we couldn't engage and wire the LAD and circumflex, and we tried the first step of pre-dilatation using 2-0 balloon, and after pre-dilatation still we have a very good waste of that one damping of pressure once we got near the ostium of the left main. So we upgrading the pre-dilatation using non-compliant 3-0 balloon, and this is a step that we are doing now, and we'll show you what is the results. A very important information that we want to conduct to you, that we, after pre-dilatation with 2.75 non-compliant balloon and adequate pre-dilatation, still coming near the ostium with the guide, resulting in dropping of pressure. So we'll go for IVUS guided examination to see the whole story of the left main and LAD, and we'll also show the circ to know where to start and where to stop our stenting, and to know the sizes and to optimize our procedure. This is very, very important, just to want to translate the data happening now on the case. ده في برانش فوق، ده مش ديسكشن.
في برانش عند الدكتور ليلي.
Now, after several pre-dilatation using escalating the balloons from 2 to 2.75 non-compliant and 3.5 to the left main, we start to think about how to stent this lesion. We realized already that the circumflex is free, circumflex ostium is free of disease, so we'll go for provisional single stent strategy. We discussed about the options and whether we go for bioscaffold or metallic stent. So our preference was to go for a scaffold to allow the left main and to be dilated as usual, and the stent cannot be an obstacle and needs further dilatation by the time, or to be stented again with another large caliber stent. So we chose the bioscaffold. Unfortunately, the left main was too small in the lens, as much as 10 millimeter, and the the bioscaffold and even metallic stents were the least was 13, and in the bioscaffold, this is for the metallic, and the bioscaffold, the least length was 20. So we choose to have a bioscaffold 3 by 20 just to cross over the, this is the bioscaffold?
No, this is the balloon.
The balloon.
3.4.
Okay, the bioscaffold we choose to use 3 by 20, and we found that after pre-dilatation there is something in the distal left main that's so tight, and Ivas showed us the LAD is normal and the disease is strict to the left main. But unfortunately, we'll go to scaffold from the ostium of the left main to few millimeter inside the LAD, crossing over a healthy ostium of the circumflex. Now we are dilating, after dilating the left main with 3.5 non-compliant, we are dilating the ostium of the left main by 3.0 to have one-to-one preparation of the lesion before putting our scaffold crossing over from the left main to the ostium of the LAD. This is a final dilatation of the ostium of the LAD by the balloon non-compliant 3.0, and we'll go for putting the scaffold just now, and we'll show to you the procedure.
When we put the guiding again inside the ostial left main stent, that the guiding should be pulled in over the balloon, not without the balloon, or it will spoil the ostium, the stent in the ostium.
Okay, out.
Now we have a very good point, as Dr. Basim said before. The guiding is inside the left main. The pressure is good. Take a picture.
Okay.
We are perfect. We have a good. That's spider. Spider. Ready? هناخد
Different shots and different projections just to make sure that everything is okay and the ostium is dilated. We have a very good sign, like Professor Magid just said. We have a good blood pressure while the guide is deeply seated. So it's very, very important a mark that we are already corrected the left main severe stenosis. This is important, and we are taking different projections just to make sure that the distal part of the bioscaffold inside the LAD is okay without any complications or dissection to the LAD, and the left main is well opened and have no stenosis or step down. Now we are doing post dilatation for the bioscaffold because we know that there is a size difference between the left main and the LAD. We are dilating strictly the left main. We give shots to Professor Magid just to mark that the balloon 3.5 are in the left main. Angiographically, looks everything is okay. but we have to go for IVAS just to make sure. IVAS, please.
ترجع
Final ram post stenting. This is a scaffold, start to appear. Well opened, well opposed, with a good diameter.
Yes, sir.
Yeah. This is the left main. Yeah. Okay. Final shot. Now we are taking a final shot. After taking off the wire of the circumflex. Very nice. And even the ostium of the third
Spider.
normalized, almost normalized.
Spider. Spider.
Yeah. And fantastic step up between the left main and the LID. Don't touch the. Okay.
شكرا شكرا دكتور باسم، شكرا دكتوره رندا على مجهودك، دكتور علي جلال شكرا، مش دعاء، دكتوره غاده، وسام من ايفس، خالد تكنيشن، كل اللي ساعدونا وكل اللي واقفين في الاوضه الادفايسز الجميله.
تسلم يا دير، تسلم
واداره
بتعملوا حاجات
المعهد
جميله جدا.
دكتور اسامه محمد اسامه الدين اوف وسانك، دكتور محمد اسامه الدين اوف ناشونال هارت انستيتيوت، ودكتور يسري كامل الفايس دين فور ذا سبورت. And also the gift idea of Dr. Hani Ragi, when he put this, so he gave us the idea of using the bioabsorbable stem. We thank you.
And finally, thanks God, we could fix the left main disease of this boy. We have a lot of uncertainties and a lot of technical problems that we could overcome during the procedure. First, engagement, because there is the curve of the take-off of the left main was extremely abnormal, looking upwards with a curve like the banana curve of the left main. So and adding to the problem, the aorta is narrow. The aorta of a young boy was so narrow. So we could manage through different shaping of the caster. We changed the tip of the caster, and we finally engaged far away from the ostium by by using GL 3.5 and reshape its tip just to looking to the left main, and we try to trap the wire inside the LAD and circumflex, then standing with the guide just 1 or 2 millimeters far away from the ostium to avoid damping of pressure. Then we start the process of pre-dilatation using escalating balloons. We start by 2 or 0 and 2.75 up to 3, just to have some room for the guiding caster to be seated in the LAD and continue the procedure of stenting. After successful pre-dilatation, the decision was the size of the available stent or bioscaffold, and there is help from our seniors, that Professor Hani Ragi and Professor Yusri Kamil, Professor Magid. It is justified to use bioscaffold, and we had the bioscaffold of 3. Just after IVAS runs, that we have the sizing of the LAD and left main, that we found that the LAD is 3.3 and the left main is 3.6 or 3.8. So we go for 3 and bioscaffold 3 by 20. We started from the left main, and there is a problem with the left main, that the left main length is 10 millimeters. So taking into consideration that the ostium of the circumflex is free of disease, we go for a single provisional stenting using this bioscaffold. We have no data about recrossing the bioscaffold and doing side branch dilatation and doing kissing, but we were ready to do this just in case we have some disease shift or black shift to the circumflex. We stented from the ostium of the LAD to the left ostium of the left main to few millimeters inside the LAD. After having the measures by the IVAS, we putting the bioscaffold at its assumed pressure, riding with the same techniques after good dilatation in a 1-to-1 ratio BRE, and after putting the scaffold appropriately, we had post dilatation with the LAD with the balloon of 3 and the left main with the balloon 3.5. We have a lot of uncertainties about successful. We have some pinching of the circumflex that was treated successfully by IV nitroglycerin that normalizes the ostium of the circumflex. Now we had a successful procedure. We have marked uncertainties about the drug treatment, treatment of hyperdyslipidemia, the duration of antiplatelet therapy, dose adjustment of everything according to the body size. This boy is 12 years old, but his body weight is 25 kilogram, and he has BMI very low for age, and very low, that mandates certain maneuvering and manipulation of the doses of the drug. We will continue supporting this boy having PCSK9 in addition to dual anti-hypercholesteremic medications of high intensity statin and ezetimibe. On top, we'll add PCSK9, and we will continue DABT for at least 12 months, and we'll follow the doses and the progress of disease. Hopefully, after 1 year, we can have some sort of mud-slice CT or re-angiography to know that everything is okay. Hopefully, that we can control his LDL to avoid any new events, whether inside the stent or another place. Thank you so much for follow-up, and we hope that you enjoy the case. Thank you.